Hello, my name is Dr. Ronald Prane. I'm an adjunct professor here at the University of Texas Dental School in Houston. I'm double boarded in both orofacial pain and dental sleep medicine. I have been involved in combination therapy since its development, and I'd like to share some information we have about using combination therapy for the treatment of obstructive sleep apnea. The title of this presentation is The Role of the Dentist in Combination Therapy for the Treatment of Obstructive Sleep Apnea. This is my bio. You can pause it and read it if you'd like. But basically, I have been involved with combination therapy, and I'd like to share some research and how to apply it to your everyday practice. I do have a conflict of interest in this presentation, and it has to do with the Fusion Custom Mask, which we'll get to later in this presentation, but I've not received any financial stipends from them, or I will not receive any financial gains from this presentation at all. At any time while viewing this video streaming course, you can simply take a break by pausing your computer. At the completion of this course, of this lecture, you'll be asked to take a short exam in order to complete the requirements for streaming video courses. At the time, you'll receive instructions regarding taking the exam. Basically, this course is about combining two different therapies. We're combining oral appliance therapy as well as CPAP therapy. I am a boarded sleep dentist and lots of experience, of course. I'm going to try to show you, first define it. There's two types, there's type 1 and type 2. And then I will also review research on both of those types of combination therapy. Then I will go into the protocol and rationale for this option from the dentist's point of view that will be presented from a clinical perspective in order to implement this into everyday practice. Learning objectives. I want you to understand both the clinical rationale for combination therapy, and I want you to understand the practical implementation of this into your patients, especially those who fail CPAP and oral appliance therapy. I want you to understand the decision matrix of this type of therapeutic options and how it is integrated into oral appliance therapy, because it is a type of oral appliance therapy. It is essential to know, and you cannot do combination therapy without a close collaborative relationship with a sleep physician when you start doing combination therapy. And I will emphasize that as we go along. And I want you to take this advanced information and practical knowledge and increase your successful outcomes in oral appliance therapy, because that is the beauty of this type of therapy, is that you're able to keep the patient in therapy when things are not going well. All right, you got all that? All right, let's roll. Combination therapy. To raise new questions, new possibilities, to regard old problems from a new angle requires a creative imagination and marks real advance in science. That is what combination therapy is all about. It's taking an old problem and bringing creative solutions in order to advance science. I want to give you a bit of a history. When you know where it came from, you're going to see the importance of this type of therapy. It started back in 1993 up in Dallas, Texas, at the Dallas Rehabilitation Institute. Dr. Joseph Varoslav was treating patients who had polio as a child. And as these patients get older into the later years, the nerves start dying, the motor nerves start degenerating. They start out with they can't walk, and then they can't move their arms. And then they basically get to a point where they can't even breathe, and they die. And so back in the old days, the only way you could keep these people alive is to put them in iron lungs that would breathe for you. Then came the development of ventilators that could be strapped to the back of the wheelchair, and it would allow, with the patient hooked up to the ventilator, would breathe for them and they'd be more mobile. Now, postprandial patients get apnea just like regular patients. But they have unique breathing challenges. The ventilators that they use are 45 to 65 centimeter water pressure. Now where that is in correlation with sleep apnea is CPAP machines that we use only goes up to 30 centimeter water pressure. So when you're getting up to 45, 65, no mask could hold that much pressure. These patients cannot breathe without assistance, and so therefore the CPAPs are ineffective. Because what happens at night to these post-polio patients, like during the day they will hold a device that is connected to the ventilator up to their mouth, and they will close their lips around it and it will breathe for them. But at night, of course, they can't hold this device, and so they have to have complete assistance by the ventilator, hands-free, which would require, of course, a mask, but they leak. And they are not very effective. So Dr. Keith Thornton, I want to mention him here because he is the inventor of the custom face mask and basically combination therapy. The mask was developed by Dr. Thornton from an impression of the patient's face. They attached the mask to their ventilators at night. Now by doing that, he was able to stabilize the mandible. There are no straps and there's no leakage. You have a perfect interface from the ventilator through the nose and mouth into the lungs without any leakage at all. So back in '93, they were having struggles with these things, and one of the respiratory therapists, her name is Sue Sorter, had a family member who was sleep apneic, had Dr. Thornton. He just had invented the TAP oral appliance, and she thought she could call on him. And so he started seeing these patients, and he looked at them. He says, I determined that not only could I improve the mask that she brought in, because they were trying to have a mask, but it wasn't working, but improve the whole technology using dental techniques. This was his first patient for this combination therapy mask. Her name is Dorothy. I actually got to meet Dorothy up in Dallas last year, and she is such a sweetheart. It's a shame that the nicest people get issues like this. But you can see on the right side there where she has the hose coming from her mask goes towards the back of the wheelchair there. That is where the ventilator is. And then the mask was designed so the ventilator could be hooked up at night and she could breathe with that. To get a close-up on this is one of his next patients with Deborah. I have not met her. And you can get on the image on the right again, you can really see the detail of how this mask was designed at the time. This was the first one he actually did. You notice the blue nut, we call that the blue nut, and it's attached to a post. That post goes into the mouth and is attached to an upper and lower shell they're thermocurled together as one unit. So it stabilizes the mandible, and the post comes out the mouth, and they attach the mask to the post with a little screw there, an Allen wrench. So those are put on every single night, and the patient is able to breathe. Now, to make the mask, you have to take an impression of the face. Well, that became a problem because the patients would basically have to hold their breath because you're covering their face with alginate at the time. That's what he was using. So he decided to put them back into the iron lung, and the iron lung could breathe for them so they could take their impression more calm, more relaxed. So that's what he did. This is Dr. Thornton and myself. We're taking impression on this lady, and you can see she's in the iron lung, and on the right-hand side you can see the mask, the impression that we're taking for the mask. Now, a little story to touch your heart, and this is something, if you see these patients, you don't have a heart if you don't really want to help these people. And before we put her into the iron lung there on the upper left-hand side, she asked us to stop, and a tear came to her eye and she started to cry, and we said, oh, is this too difficult for you? Do you want to do it tomorrow? And she goes, no, I'm laying here going into this iron lung, and my image comes. I spent the first 10 years of my life in the iron lung, and I can just see my mother over there crying because I'm in this device for the rest of my life, she thought. And so we said, okay, and then she said, okay, let's go. And so she went. She was an excellent patient. But that's how you would take an impression. You won't. probably never come across this, but that's how Dr. Thornton developed this technique by working on these types of patients. And of course, I was there, so I said, hey, can I go in an iron lung? Because I doubt if many people have this opportunity. And so they put me in an iron lung, and that's me in the iron lung there. And I looked up in the mirror and I realized that that was the patient's world. Everything they saw was through that mirror, and you can see what a small world it is. And they started the machine up and they asked me to count backwards from 10, and when I got to 5 I was mouthing the words but no sound was coming out, because you only have sound when you breathe out. But when the machine was breathing in, it did it. I couldn't stop, I couldn't control my breathing rate or anything. It was really the weirdest feeling I've ever had. But that gave me a sense of these people, and that back in the 30s, 40s, 50s, they had huge rooms for these things, because that's the only way they could keep these people alive. So from there, 94, 95, 96, Dr. Thornton started tinkering around with this device and trying different ways of attaching a CPAP to the post, and different types of masks, and trying different designs to make it more efficient, more economical, more last longer, and trying to achieve more efficacy of the mask. And these are some of his later ones. He's an engineer and he kept trying to do new things. So that's the history of basically combination therapy. It's a dentist who was presented with a need, and he met the need with his expertise, imagination, and knowledge. So that's a great story for dentistry. So what exactly is combination therapy? It is not, first off, it is not attaching a CPAP to some type of oral device. These are examples of oral devices that are attached to CPAPs, but if you notice, none of them attached to the mandible. They're all based on the maxilla or held there by straps. So those are more of what we call hybrid interfaces. They're not really, because mandible is not even involved in the situation, in the treatment at all. These are some samples of combination therapeutic devices, which I'll get to more in later, and you can see they range from nasal pillows, the full mask, to just nasal masks, and of course they're the boutique line with all different types of designs. So when you talk about the word combination therapy, technically you can combine any two therapies and you have combination therapy. You can combine oral appliance therapy with CPAP. You can combine CPAP with positional. You can combine positional and myofunctional. And surgery and oral appliance, or surgery. Hypoglossal nerve stimulator, the new kid on the block, may not be effective. Then you have to do oral appliance with it. So those are all combination therapeutic modalities, right? But for this lecture, I'm going to be talking about the two most common therapies. Number one is CPAP, and number two is oral appliance therapy. When you combine those two therapies, which by the way represent probably 98% of all therapies, then you have what we're calling combination therapy for this particular lecture. So I had to give a talk back in 2008 or 9, about combination therapy, and there was only a few of us around the country doing it at the time, so I got them all together, all of my colleagues who are doing this, and said, how should we define this, because no one's ever done that yet. And so this is the definition that we came up with. It is a CPAP interface to the nose or mouth or both that is either in conjunction with the mandibular advancement splint. That's what we call dual therapy, which I'll get to in a minute. In other words, they're both being applied at the same time in conjunction with, or one that connects the CPAP hose directly to an oral appliance. That's called integrated therapy, type 2. But both of them feature mandibular stabilization. That is the critical aspect of combination therapy. That's the part of the therapy that physicians get. They know that is needed for those patients who need combination therapy. They're looking for to stabilize the mandible because that's where all the leakage is occurring for CPAP. So combination therapy is fairly new. It's an emerging therapeutic option being taught around the country more and more now. We're starting to test on it. But like anything else that's emerging, it comes in stages. The first stage, of course, is observation. Dr. Thornton did that. He observed the problem and he came up with a solution. The second step in the scientific method, so to speak, is experience. You start working with it, you start seeing how patients respond, you start modifying it. Well, that's been done and is still continuing. Then comes the hard part, which is research. Research has just started, and I'm going to go through some research that I have found and one that some of I have done myself. And when you put research out into the academia, they respond to your research, they challenge it. And as those challenges come forth, then you start getting validation of combination therapy as being an accepted therapeutic modality. So the first couple of studies I want to review real quickly here is on dual therapy. Now there are not that many studies on combination therapy at all, so I had to reach far back into the PubMed to find some of these. But the first one I want to show you is done by El Sol, and he just had 10 subjects, which again is a very small group. But they're basically intolerant to CPAP, and all he did was add a Herbst appliance to it, a mandibular advancement device. So the results were, from those 10 patients, the CPAP pressures went from 9.3 to 7.4. They were lowered, which we do find when we combine the two therapies. The CPAP pressures are able to be lowered. The residual AHI went from 11 to 3, which means that it did resolve the apneic, hypotonic events. And of course the Epworth Sleepiness Scale, which is the measurement of their fatigue, went from 12.7 to 7.5, which means that the patients were feeling better. So he addressed both the objective and subjective aspects of therapy. His conclusion was, and this was 2011. These are all pretty recent because this is just starting up. Combination therapy of MAD and nasal CPAP is effective in normalizing respiratory disturbances of sleep apnea in selected OSA patients who are intolerant to CPAP. So you can see when he published this, they're starting to see indications for combination therapy, and that is one indication to this day, those who are intolerant to CPAP. This is 2015. Alpadhe just did a case report. The fact that I'm reviewing a case report underscores the need for more research on this subject. But this case report was a patient who was intolerant to APAP, which is the auto PAP, and all he did was add an MAD. When he did that, the PAP pressures the first day were reduced 33%. And day 90, after 90 days, it was reduced by almost 50%. The apneic index went from 12.7 to 6.5, cut in half. Okay, so his conclusions were, in such situations, non-compliance and air leaks, which is an indication for this device, alternative methods of treatment need to be looked at so as to ascertain better management. And his conclusion was, mandibular advancement devices along with CPAP combination may show better treatment outcomes in specific situations. Well, that's pretty astute from one case, but he must have seen more and more of these, and that's when he came up with this conclusion, but it does fit this one case. Now let's talk about integrated therapy. Both of those previous studies were dual therapies. All they do is add an oral device to a patient already in CPAP, or in this case APAP. This is the first study on integrated therapy, and of course it was done by Dr. Thornton, and it again was a case report, 2002. He had a patient who was APAP intolerant, that's the auto PAP, and the patient could not wear a mandibular advancement device because of their TMJ. That right there in a nutshell is what I would say is the indication for combination therapy. You have to fail both therapies. So he used what they call a TAP-PAP nasal pillow, which I will show you later. But it's basically nasal pillows of a CPAP connected to a TAP oral appliance. So the PAP pressure is reduced by almost 41%. Now, you may say, yeah, what's the big deal about that? Well, let me tell you. CPAP goes from 0 to 30, right? Well, every time you go up 1 centimeter water pressure, it's not a 1 unit jump. It's a logarithmic increase. And so normal pressures for most people are around 10, 11, 12. Then you start to get up to 15, and then you start to get in towards 20, and they're so high, it's very difficult to even breathe against. So it makes CPAP experience, those are the ones who walk away from it, I can't stand it, it's just too much. And so if you can reduce pressures by 41%, that's big, because then you're going from like 15 down to 11. And so that's much more tolerable for the patient. Another case report done by Dr. Martin Denbar up in Austin, 2012. This was on a military man. He had CPAP alone, his AHI was 20 and his central apneic index was 26. And that is with the CPAP, so the Army was going to discharge him, and he came to Dr. Denbar, and with the help of Greg Estick and Shram Pritam, they took the TAP-PAP nasal pillow, which is what I just described, and applied it to his case. The AHI was completely eliminated. He had no more apneic events. To their surprise, the central apnea was eliminated too, which means that what they're talking about with central there is what they call mixed apnea. In other words, the obstructive events were triggering the central apneic events. But they were eliminated. But interesting enough, there was increase in RERAs, increase in respiratory effort-related arousals, which means what I think, and I interpret this, is that the combination device brought the therapy down to the point where the body is now saying, wow, I can handle this, I'm going to help this device, and we can get this eliminated. RERAs are effort-related arousals, which means the brain is helping the therapy along, which is okay. I mean, that's what it takes, that's what it took. This just came out 2016, DeVries. And I had a few little concerns about, especially the conclusion. I haven't talked to them yet exactly how they did it, but I know Nadav and Holkema personally, and they are really good clinicians, so I'm certain this is a good, valid study. But they only had 7 patients. And these patients were CPAP intolerant. And they added the TAP-PAP CS, which is the nasal pillows. And I don't really know what the pressures were and how severe these patients were. So they were able to lower the pressure, just like all these other studies I've showed. And it seems like a comfortable alternative to conventional CPAP, but they didn't find any differences between compliance satisfaction. And that's where I kind of would challenge that, because I have found a lot of differences, and I'll show you a study at the end of the lecture here, what I did on my patients there. So their conclusion, though, is dead on. Combined therapy is feasible in obstructive sleep apnea syndrome and should now be investigated in random controlled studies, including the assessment of comfort and long-term compliance, which I think they realized that we need to look at this further, because perhaps their data was maybe biased somehow, I don't know. But that's exactly where we are right now. We need more random controlled studies in order to validate this therapeutic option. So I did one last year. Actually, it got published last year, but it took me 3 or 4 years to do, like these things go. Healthy respect for researchers, I tell you. I teamed up with a physician, Dr. Swick, down here in Houston, and we took 75 of my patients who were in the integrated therapy, and they were actually in the custom mask integrated therapy, the face impression custom mask. And I wanted to see where these patients came from, what had failed that got them into using the custom mask, what didn't work. And I found that 57% of these patients actually failed CPAP. And I took this subgroup, and these CPAP patients who failed CPAP and went into the custom mask, their pressures were higher than others in the studies, and they were struggling the most because their disease was much more severe than the others in the study. But we're able to reduce CPAP pressures, and we had long-term compliance. In 10 years, some of these patients have the custom mask for 10 years. And of course, when you take the fact that this mask lasts for 10 years and compare it to the cost of a stock mask over 10 years, it was more cost-effective. So I'll come back to the study later and share with you some other things off the study. But right now, this is the most robust study in combination therapy, and something that we need to build on. My conclusion was the application of custom face mask for patients with more severe OSA. In other words, the custom face mask integrated therapy should be considered when the patient's obstructive sleep apnea is severe and is well tolerated with improved compliance. The custom face mask should be considered when all other therapeutic methods of treating OSA have failed. In other words, oral appliance fails, CPAP fails, or when the CPAP or CPAP mask are intolerable to the patient. So this just came out last April 2017. I'm recording this in 2018. So when you're looking at combination therapy, what do you have to have? Okay, number one, just like oral appliance therapy, which is a subgroup of that, you need a proper diagnosis by a sleep physician and treatment by a dentist trained in oral appliance therapy. Now you notice you don't have to be trained in combination therapy. You have to be trained in oral appliance therapy, because that's the basis of this option here. I'll get to that in a minute, but let's look at indications. When would you consider oral combination therapy? Who would you do it on, and why? Well, the first indication is you have to fail oral appliance therapy, right? In other words, if oral appliance therapy worked, you wouldn't even need to consider adding CPAP to it. But you know all the reasons for oral appliance therapy. You have the three main ones are TMJ issues, tooth movement, and bone changes. Those are the three main ones. Then you have all the minor ones, like sore muscles and all those who do oral appliance therapy know the whole list of them. But those you get to a point where you have to say, I just cannot progress the mandible anymore, and we have not resolved the apnea. Or this patient just cannot wear this, they can't tolerate an oral device. That's one thing. Two is you have to fail CPAP. In other words, if you take your oral appliance patient and send them over for CPAP and they love the CPAP, you would not need to do combination therapy, because the CPAP is being effective. The patient is wearing it, they're being treated, and life is good. But we all know that CPAP compliance or CPAP success is about 51% around the nation. There are some physicians, of course, who do a better job than that, but overall it's 51%. In fact, success rate for CPAP, according to Medicare, is 4 hours a night. Greatly, in my mind, ineffective in the real world. If that's all they get is 4 hours a night, that's not going to give you great health outcomes. So if the CPAP is intolerable, or if it just doesn't reach, why would not CPAP work? Well, if a patient is extremely obese, very large tongue, retrognathic, CPAP may not even work for these patients. This has to be a failure of CPAP and oral appliance therapy. Now look at these images for a second, and this is a patient, one of them is me, who are on a nasal PAP, right? Now the way this goes for CPAP and the way it works for physicians is first you try a patient on the most comfortable mask of all, and that would be the nasal pillows. Little airy nasal pillows are wrapped around, a strap around the ear, and it's just floating there and very comfortable. And for some people that works. But for some people, they don't like that thing stuck in their nose, and they don't like the straps on their face. And so the doctor will then go to a nasal mask. You see, nasal pressure patients people were created to breathe through their nose at night. But then you have all these other issues, septal deviations, hyperturbinates, and you have mouth breathers, and you have all these things going on. But that's the best way to deliver pressure. CPAP is pressure, not blowing air in the throat or in the nose. It's blowing pressure. And so you put on a nasal mask, and okay, now the pressure's going in, or nasal pillows. It goes up the nose, down the back of the throat, and hits the base of the tongue. And it has to push, the pressure has to be strong enough to push the pressure, to push the tongue interior so that the patient can breathe. That's what CPAP does. Now, if the patient has a larger tongue than the pressure can deal with, then the pressure will say, I gotta get out of here, I'm gonna go out the mouth. And then it starts leaking out the mouth. So these are patients here with nasal mask, and the air is leaking out the mouth. So what does the doctor have to do? Well, first thing he's going to do is just add a chin strap to keep the mouth closed, to help the seal maintain itself so that the CPAP will work. But look at this chin strap. Do you see what it's doing here? It's distalizing the mandible. So the mandible gets distalized. It increases the pressure on the airway with the tongue base, and it starts to close up the airway. And so what's the solution? You have to turn up the pressure, make it stronger to get past the now smaller airway, and pretty soon it starts leaking out the mouth. Then the last step option these physicians have to treat these patients are full mask. A full mask, the image there on the left, the patient's in a full face mask. It goes over both the nose and the mouth. And that is then strapped to the head by several straps, and they're tightened. And then as you tighten this full mask, again, it distalizes the mandible. Here's the problem with a full face mask, is when the patient slightly moves their jaw or moves their head, the mask shifts and they get a blowout, like a and it wakes up the patient, or it just leaks out, and there you got leakage again. And so these full face masks are really challenging for the physicians. So the first type of combination therapy is called dual therapy. It's combining two therapies at once. It's simply the patient's on CPAP, the dentist makes an oral device and applies it to the patient at the same time. Now, the dentist, his role in this is simply to make the device. And when you make the device, you only have to advance it 2 or 3 millimeters. Because what does an oral device do? How does it function? Well, it functions in 2 ways. One is it actually physically opens up the airway by advancing the tongue forward, right? It opens it up anterior, posterior, but also laterally. Number 2, it stimulates the genioglossus muscle, the tongue. And so it stiffens up the tongue, which helps support the airway. So you've got those 2 things going. You don't have to advance them very far in order to accomplish those goals. So just by advancing and stabilizing the mandible, CPAP therapy is much, much more effective. And that's something you achieve the critical mandibular stabilization, and it's something that's easy to implement into general dental practice. If you already know how to do these devices, then you will be able to do combination therapy tomorrow morning. You go to your physician and say, hey, this is what I can do for you. You don't need any special training in combination therapy because the physician is managing the CPAP. He's managing, as he's supposed to, the whole disorder of obstructive sleep apnea. All we are doing is managing the airway. The cost, insurance, you already know because you are already doing it with oral appliance. You're just charging them out for an oral appliance. However you're doing it now, you just keep doing it the same way. So the dentist would fabricate the MAS and the physician would then manage the CPAP machine. Like I said, bring in about 1/3 protrusion. I just say 2 or 3 millimeters. And then you have to send the patient back to the MD for a CPAP final titration because remember those studies? Yeah, all the CPAP went down, CPAP pressures went down. Now, Dr. Simmons down here in the Woodlands, he did an abstract, which abstract means that you publish findings from a cursory look at research that you are doing. And like, hey, this is what I'm seeing over here, this is what's going on, and then you publish it, and that becomes an abstract, and then we're supposed to take these abstracts and continue our study, and sometimes we do, sometimes we don't. Well, this was a simple 10-patient study. One did eventually drop out, but the 9 that stayed in, like all of them failed full mask. He did that full mask, he had leakage, it didn't work, and they were going to abandon therapy. They said, we can't tolerate the CPAP. And so he made I helped him, a snore-free boil and bite. And as I went up to the lab, I stuck it in hot water, put it in the patient's mouth, advanced a little bit, and then have them squeeze down. It's just a temporary device. And then they were able to wear that through the night and wear it for the next few weeks. And we did a survey, and they all said they're much more improvement. We not only had statistical improvement in the treatment of the apnea, but we also had improvement in subjective findings as well. And so that was just a simple dual therapy study that we did real quick. But it definitely underscores the therapeutic advantage of using oral appliance plus a CPAP machine. Type 2. Type 2 is integrated therapy. Now we are integrating the two therapies together into one. The key is the interface between the CPAP and the treatment in the head. And these are a couple of samples here of the devices, which I'll get to more in a few minutes here. But the image on the left there, that's a TAP-PAP CS. CS stands for chair side. After you make the oral device and the post is sticking out, it's called a monoblock, then you just screw on the TAP-PAP CS and off you go. They're very simple, very clean, very quiet, very effective. Nothing's touching the face there if you look at that. The only thing touching the face is along the nares on the nose there. The one picture in the middle is a modified custom mask. And we made a custom mask for her, and she couldn't tolerate it touching her skin. She had trigeminal neuralgia. So we had to cut the mouth aspect of the mask off so that she could tolerate it, but it worked very well. And of course the image on the right is the full custom mask. Now, while we got this view on here, you'll notice the hose goes up to the nose. Now where it enters the nose there is called the nasal vestibule. And that's separated from the section below where that post is coming out, where it attaches to the teeth. They're separated by acrylic. And so that's the mouth vestibule. So you have a nasal vestibule and a mouth vestibule. And the beauty of this mask is that we can guide the air every which way. We can guide the pressure into the nose. We could take out that acrylic separation and we'll go to the nose and the mouth. Or we can seal off the nose and have it just go to the mouth. And there's indications for reasons to do any of those things. But that mask is very flexible. And now I'm looking at this. Look at the nose. All right. See where the bridge of the nose is? That's a very big area of complaint for patients with the CPAP mask, especially the full ones, because that skin up there is very thin. And they come in with sores on the bridge of the nose. And I had a patient come in who developed cancer because of the constant irritation. And so this mask is designed not to support itself on the bone of the nose, on the bridge there, but rather to grip the soft end of the nose to make the perfect seal. So we're connecting the CPAP directly to the mandibular advancement split. It offers a couple advantages. One is the stability of this mask. Just think of it. We're connecting this mask to the skull base via the dentition. We put an upper and lower shell. The teeth bite into it. There's a post that goes out, and we connect the mask to that. So that's where the stability comes from. You don't need to put the mask up to the bone of the nose because it's stabilized by the teeth. Also, we have found, and I have a little abstract about this, excellent compliance and satisfaction, because main reason why people abandon CPAPs are the straps and leakage. It's in the research all over the place, and I also did that too. But the lack of straps, because we're connected to the teeth now, we don't need any straps, and there's no leakage because you can sleep on your face, on your side, because it doesn't move because it's attached to the skull base. It doesn't float around the tissues like a regular CPAP mask. They have that seal that blows up with air and just kind of floats on the face. They may be comfortable or not, but it definitely doesn't stop the leakage if it's going to happen. Again, we advanced the mandible with this device, these two devices. I advise it always if we can. And once in a while you get a patient who can't tolerate any advancement, but it's still going to work just fine. Now, in order to implement this therapeutic option into your practice, you have to get special training. And I'm working to change this, but right now we have to learn how to take a face impression. And so if you desire that, the only place to get that training right now is FusionCustomMask.com. It's my company, and this is probably a conflict of interest. I'm not promoting this at all. And I'm always looking for other ways. In fact, we're trying to eliminate training so that we won't need this anymore. But you need to also become familiar with CPAP therapy. And so when I give my courses for this, we always have a physician come in and talk about CPAP. And they may need to stock a few parts. It's difficult to implement in the general dental practice because this technique takes a very highly trained staff, and it's a time hog. It takes up a lot of time. And the more you can train your staff, the less chair time it is for the dentist, and that's the key to the profit of this type of mask. But it also varies, because sometimes a patient comes back from adjustments, a simple little, oh, you're leaking a little bit here, fix it, or it may come back where you got all these issues going on. And so you never know how long the appointment's going to be. So I always have a patient come back for like 45 minutes with a clinical staff member, and then if she needs me, she'll come get me, or my time is at the end. So give the staff member time to work out these issues, but that can be frustrating sometimes with the schedule. Insurance is not really known right now because there is no code for these masks. We're helping Medicare develop one right now as we speak. But the code that we use is for oral appliances right now. And you're thinking, that's not an oral appliance. Well, actually it is. It's attached to shells that go on the upper lower teeth, and we do advance the mandible. That's oral appliance therapy. If you don't advance the mandible, you're not really doing oral appliance therapy. So this is the study I did, and this is an abstract. I took 10 patients in a custom mask, which is in the blue, and satisfaction line along the bottom. 1 is more satisfaction, 5 is less. And you can see the red is the stock mask, and it's like opposite. Much less satisfaction with the stock mask for CPAP, and much more satisfaction with the custom mask. And so I think that kind of is not consistent with one of those studies, the DeVries study, but it may be just the bias of the types of patients we all used. But this was my observation, and I published this in 2010. Okay, so what is this custom mask? Now the dual therapy you got, right? You can do that Monday morning. You can go to your physician and say, hey, I can do this for you right now. And now you're thinking of more, let's do some more advanced stuff in my practice. Let's start doing this integrated therapy. Okay, so that's the Fusion, the company that I started for this combination system. So there's basically 2 styles at this present time of CPAP interfaces. Dr. Thornton has the patent on all these 2 devices, and I have the exclusive license to fabricate and teach and do research on the Fusion custom mask. The TAP-PAP CS stands for chair side. And you can see, like I explained before, you're just taking this nasal pillow and screwing it onto the post. And that's all there's to it. Very simple, very quick. Patient comes in, and you're thinking combination therapy, and what do? I don't want to do a full mask because there's all these other steps and it's more costly. I'm just going to try this first. So the first line of treatment would be the TAP-PAP CS. Now here's the thing. CPAP pressures on these devices. The TAP-PAP CS, if you look at it, the pressure goes in the hose and into the nose, and then the airway is opened up because you're advancing the mandible, and the mouth is sealed by these oral devices, right? Well, on pressures from 1 to 15, it works really well if the patient can tolerate those nasal pillows. Sometimes they dry out the nose, sometimes they irritate the skin, sometimes they just feel like they're pushing in there, and the patient doesn't like that. So then you move on to the custom mask. But we have found in this device, when the patient's CPAP pressures are over 15, you get leakage out the side of the shells, between the shells and the cheek, and you get fluttering of the cheeks. It sounds like a horse, and it wakes up the patient. That's mouth leakage is occurring, and it becomes much less effective, and also wakes up the bed partner. So then you would move on to a Fusion custom mask, and there's even more indications for the custom mask, but one of them was the failed TAP-PAP CS. Now the Fusion custom mask has a perfect seal, and the thing about this is, if you look at it sitting on the face there, we don't push it into the skin. We take an impression of the face and we exactly duplicate the skin, and it lays on the skin. You don't need a soft liner because it's polished acrylic, and it's laying on skin, and when the air goes into the nose or into the mouth, it pushes the skin back against the device, and therefore the seal is accomplished by actually pushing the skin into the mask instead of the other way around. So the way the system works that I kind of am still working on, but right now the way it stands is that you start out with the oral device first, and you have to fabricate the oral device. You can either use a DreamTap or a TAP 3. Now the TAP is a Thornton anterior positioner with a hook and a device. All right, and then you get a post that we would send you, or you can get from AMI, and the post can screw directly into the TAP device. And then you have the oral aspect of these combination devices. Or if you're using another appliance, you can't attach a post to any other appliance other than a TAP, then you would get a Fusion monoblock made. Now a monoblock is the simple upper and lower shells, dual laminate, and we attach a post to those shells with acrylic, and then you'll end up putting them together, which I'll talk more about in a minute. Then once you have the oral aspect of the device, then you have a choice. You could either do the TAP-PAP CS, or you can do the Fusion custom mask. Now the TAP-PAP CS comes in a bag, and you open up the bag and you attach it to the TAP post or the monoblock post. It's simple to do. The assistants can do most all of this. You just have to come and check at the end. It's fully adjustable. That little device is amazing. It can go every which way and even rotate. You can add an extra headset for the hose if you want to keep it over your head, but otherwise it kind of swivels to the side, back and forth. And again, it works best for CPAP pressures under 15 centimeter water pressure. This are the two options you have. You have either the TAP 3 or DreamTap, and you attach the post, and this is illustrated by these images here, and then you attach the TAP-PAP CS. Or you have what we call the Fusion monoblock. You just take a couple of impressions, one upper, one lower, send it to the lab, and we'll create that mouthpiece for you. So the step-by-step procedure is, phase one is you would take the Fusion monoblock or the TAP-PAP with a screw post on it. And then number two is you thermocryl them together. Thermocryl is a thermoplastic acrylic that at 160 degrees turns into a gel, a clear gel. And when you go below 160 degrees, back to temperatures, room temperature or mouth temperature, it becomes a fairly hard white material, and it adheres the two together. So you can put that between the two shells, and you have the patient work with it, and you get them advanced about 3 millimeters, then you blow air on it with a syringe, air syringe, and it cools into 1 unit. That's called a monoblock. Then we're ready for the face impression. This is for the custom mask now. And this was published in the Journal of Prosthetic Dentistry by myself and Dr. Colquitt out of Louisiana. We did these on a patient, and you can see the technique pretty clearly here. Number one picture in the upper left is the 2 monoblocks with the post sticking out. And then we plug up the noses, the nares, the nasal passage with cotton rolls. We Vaseline the face, and we put that air tube in there. See that breathing tube that goes around the post? That's so the patient can breathe during the impression. And then the patient's laying back, they're relaxed, they're breathing through the breathing tubes, and we flow on a light body, a polyvinyl siloxane, that will go over the face exactly as you see in the picture there. And it takes 2 because if it starts setting, then you don't have consistency. So 2 people, one on either side, and you can lay that stuff on her face, or his face, and then it sets really quickly. You take this disc, it's a thermocryl disc that's infused with Kevlar, and so when you heat it up, the disc becomes pliable, and you mold it to the face. And you mold it to the face, and you go over to the Penta machine, the lower left image, and you load it with a medium body Penta material, vinyl siloxane, and you push it onto the face over the light body that's already been set, and then you pull it all off as one unit, and you can see in the lower right hand side, that's the impression looking down into the impression. It is so detailed. You can see the folds on the face. This is going to be the border of the mask. You can see the nose, the nares, and a perfect representation of the face. You send that to the lab, and in the lab, we pour it up in plaster. There's the breathing tube you can see in there, transferred with it. We use a BioStar with BioCryl discs, and we build the mask, and we have that blue nut. The original blue nut is still there. And we attach that to the post and attach it to the mask with thermocryl. And that's the result, okay? Now, the thermocryl is there because if you set this on the patient when you get it back from the lab and it doesn't fit exactly, you can heat up the thermocryl around the blue nut and you can rotate it or adjust it so it fits perfectly on the patient's face. When you learn how to do it, that's some of the things you learn how to do. So we've been able to validate superior compliance and satisfaction. These masks can tolerate high pressures because remember the history here. The history is it can tolerate 65 centimeter water pressures. Well, CPAP can only go up to 30. I've never seen a CPAP over 27, I think is the highest I've seen. It worked great, no problem. You can modify the airflow to the nose, to the mouth, or you can make it both. I had a patient one time that had Graves' disease. And this is the beauty of this mask. You can address challenges like a lot of different challenges. She had Graves' disease, and their eyes get large, and so for aesthetic reasons they did what they call infraorbital decompression. They took out the floor of the orbit to let the eyes sag back down into the sinuses, so she looked normal. Well, she had sleep apnea. She went to the sleep lab, and they put a CPAP mask on her, and what do you think would happen? That's right. The pressure went into the nose, into the sinuses, and popped the eyes out. And she put it back in and said, I can't wear a CPAP. So she came to me. She couldn't wear, I tried an oral device. She couldn't, she had really severe TMJ. And so we decided to make this mask, and I completely sealed off the nose and guided the pressure into the mouth. And she was able to be treated. This mask is adjustable, and we almost always lower the pressure. Every time you lower the pressure, you increase the comfort of the whole CPAP experience. So who does get a custom mask, Fusion custom mask? Well, this is came from the research article I did in 2017. So I took 75 patients and I went back and looked at where they came from, and 15% of the patients failed monotherapy, TAP3. And I wanted them to go to CPAP, Either they said, I will never do CPAP, I'm never going to CPAP, or they had already tried CPAP and they couldn't tolerate CPAP. 28% were patients who had tried to do the TAP-PAP CS. And the most common reason for failure were mouth leakage, or their pressures were a bit too high. 57% were CPAP monotherapy failures. In other words, these are the patients that come in and they have a lot of different, they're severe. They're more in that subgroup analysis revealed that their pressures are always higher. We did esophageal pressure monitoring, so those esophageal pressures were really high. And they also had a lot more comorbid problems. They have high blood pressure, maybe they've had a stroke, blood sugars are off the roof, and these people were just basically sick because they are not getting proper sleep at night. And so these are the people that you need to keep in CPAP, because oral appliance therapy is really not indicated for severe apnea. It's indicated for mild to moderate. And so we found that the custom mask should be the main application. So we took the study and we decided that the main number one indication for a custom sleep face mask are people on the more severe end. But you can use it for anything in between. The TAP-PAP CS can be used for temporary. So let's say, I'll get to Reiki in a second. Let's say you have a patient that you're doing oral appliance therapy on, and you're advancing them, and all of a sudden the patient comes back and says, I just can't go any further. I'm only 50% in protrusion, but my jaw hurts. I don't like it. My tongue's being, it just isn't working for me. I got to quit. That's when you say, hey, let's just add a CPAP for a few months to get everything to settle down. And that would be dual therapy, or you can do a TAP-PAP CS. Hey, let's just screw this post on your tap and let's slap the CPAP on for a few months till you get you more comfortable, and then we'll take that off later. So combination therapy can be used both short-term and long-term. Short-term to resolve some of the side effects and complications of oral appliance therapy, and long-term for the more severe end where they can't tolerate oral appliance at all or CPAP. Okay? So those are the main indications. Now once in a while, this is Ricky. Once in a while you get a patient, and I call them soul patients. They come in your office and they just touch your heart. They reach into your soul and you say, I want to do whatever I can to help him. And he came in that way. He was age 40 when he came to me. He was discharged from the Navy because they could not resolve his apnea. They couldn't even get CPAP to work very well. His BMI was 40, RDI was 70. That's like 70 arousals an hour. That's more than one a minute. His oxygen went down to 66%. So his PAP machine, CPAP, was set at 26. He could not even breathe against that. I don't think any of us could. That is a lot of pressure. So a BiPAP means that when he breathed in, it was 26, but when the machine determines that you're about to breathe out, it dials down to 20 so that you can breathe. So it's 26 in, inspiratory IPAP, inspiratory PAP, and 20 expiratory WAP when he breathed out. Even that wasn't working. He was still on 24-hour oxygen. He was in a walker, sometimes a wheelchair. Look at his eyes. He's exhausted. He's not, and look at his bite. Why do you think it's like that? He's already a class 3. His tongue is so large, you'll see in a minute, that is pushing his mandible forward and expanding the bone, and he's also trying to breathe, so the tongue is being pushed forward all night by the CPAP machine. So he went to the lab. A friend of mine who runs a sleep lab here called me up at night and said, hey, I got this guy up here. This is where I first met Ricky, and I just can't get a PAP machine to work. Something's obstructing his mouth and then his airway. His tongue is so large, and look at that tongue. It is huge. And so I did a boil and bite. We boiled the device and stuck it in and advanced his mandible in the boil and bite. He couldn't advance too much, but it was enough to where he could get CPAP working and he could sleep. All right, so I brought him back to my office and I took an iCat and look at that airway. and that's sitting up in alert position. It's the size of a coffee straw. He was having organ failure. He was on all these medications. They want to do orthognathic surgery, which would resolve the situation, or at least help him, but he was too sick for surgery. No one would touch him. And the BiPAP wasn't working because there's too much obstruction even for the best of CPAPs. So as a good sleep dentist at the time, this was like 10 years ago, I had just learned how to do the custom mask, and I really wasn't comfortable yet, so I said, well, let's just do a tap appliance. Look at that. I mean, that made it worse. I mean, the oil stuff in there made the box for the tongue even smaller. I tried to increase the vertical, that didn't do anything either. So dual therapy did not work for him. He was too far down the road. We're still learning at this time what to do when. So I made him a custom mask, and I put it on his face, and he couldn't tolerate touching his face. Why? Because he was so bad that he was in an extremely elevated sympathetic state. In other words, his brain was constantly wondering when the next breath is coming, and the panic and the sympathetic activation was high day and night. And so his skin was all jazzed up, sensitive to touch, and leave me alone. I'm just got to concentrate on breathing. And so what I did was I cut off the mouth part, and that was sufficient enough because his tongue was so big he wasn't going to have any mouth leakage, and it worked very well. Then we were able to get him downtown Houston here at the medical center for orthognathic surgery. But before they did that, they say, man, his tongue is large and his jaw is large. I wonder if he had acromegaly. And so they genetically tested him, and he turned out to have what they call Beckwith-Windham syndrome. Only children have this. It's a form of acromegaly, but he is the oldest known ever to have this Beckwith-Windham syndrome. And so he's a celebrity down at Baylor because of this. But the oral surgeon then said, okay, let's go. They took out 60% of his tongue. The mandibular advancement was 11, and maxillary 16 millimeters. Of course, they had to trach him, right? Because that type of surgery, what little airway is there would swell up, and he wouldn't be able to breathe. So he was in a trach after the surgery. So he came back to my office. I put him back in a cone beam, and you can see the airway had expanded. It's larger, but even then, it's not very big. But there's this thing called the Purcell's law. Purcell's law states that every time you increase the diameter of a tube, you increase the flow by 17 times, maybe 16. But that looks like it's been increased by 3. So that's a huge increase in airflow. So he came back to my office, and I was able to then fabricate him. He's already looking better. His skin tone is much better. And you can see on the lower left picture, he still has his trach, and he's doing really well. He got off his walker. His wife is grateful because she thought she was going to lose him. He did very well for many, many years, and he just passed away this last year. And I consider him a friend of mine, one of those patients who, I'm going to use what I learned from him and help many, many other people. So the future of combination therapy, in summary here. The future of dual therapy is that it can be implemented, since it can be implemented in any dental practice, it will grow as oral appliance therapy grows and become better and better. We just need to increase awareness of this therapeutic option for dentists and sleep physicians. And of course, we always need more research validation of even dual therapy. Integrated therapy, the future is, right now it's cumbersome because you have to learn how to take a face impression, which dentists don't normally learn how to do. It has to be streamlined into a practice, and it's very difficult to do in a general practice, but it can be done. You can X off days for these and things like that for these types of patients. The other thing that needs to be done in the future to make it grow and become more available is to establish relationships with the physicians, and that's what we need dentists to do anyways. The more relationships we have, the more integrated therapy we'll be able to do. It needs more research and development. I'm going to show you what I'm going to be doing in a minute here. And we always need more research, definitely more research on this. I've got a couple projects going right now, and hopefully we can get more people doing more. Then there's always profit issues. These mass costs, the lab costs, are about a third higher than oral appliances. So you got to charge more for these things. And of course, the insurance and all that. And so one of the things I want to do with this is I want to be able to do a facial scan and then send it to the lab and have them 3D print this. If I can get that done, then I believe that this type of therapeutic option will become more commonplace in the dental profession. This is an app I have on my iPhone, and that's my wife, and we took this actually in a room, and the white thing on her face is a car driving by reflecting the sun off the car. But look at the detail of that, and I just did it sitting there. If I could get this program developed to have a file, an STD file that would be able to send it to a 3D printer in the lab, what a huge difference that would make. The appointment would be like 1/10 of an appointment of what the facial impression would take. So that's the future. That's what's going on. Come back later. We'll redo this talk, and we'll bring all the new technology on board, and it'll be better this particular option. But today, I just wanted to show you combination therapy and how you can use it right now. After you get going and you're loving it, and you're seeing that you're really helping these people who are unhelpable sometimes, and you want to learn integrated therapy, go learn it. And use this option to consider bridges to your physician, because the physician can see this as something that could help him. I mean, he may not understand oral appliances, but he will understand this. And you're helping to keep the patients in CPAP, and so use this option to go talk to your physician referrals. So thank you for your attention. It's a slide to remind us where we were. This is my grandfather about 100 years ago. And look at that drill. That was his new high-speed drill. All right? Yeah, I know. So we have quantum leaps in the future where we stand on the shoulders of giants. And so that's what combination therapy is from, standing on shoulders of giants. So thank you for your attention, and that's the conclusion of this lecture. Now hang on, got more for you. Okay? So if you need any more clarification from this lecture, please send an email to this email address. And this completes the course. Okay? It's time for you to take a short exam in order to complete the requirements for streaming video courses. You will need to score 80% or more. I wrote the questions. You can do it. If you listen to this, because it's really interesting information, no problem. Upon successful completion of this exam, you will be visually informed that you have met the requirements to proceed. But it's necessary for you to take this exam and get 80% in order to proceed to the next section. If you fail to answer enough questions correctly, you will be instructed to take the exam, and a new set of questions will be provided. You have 3 chances to fulfill the requirements. You can do it. Come on. If you're not successful, you will be instructed to review the section again. So good luck on the exam. But more than that, I hope this lecture will inspire you to consider combination therapy as a therapeutic option for your more challenging patients. Thank you very much for your attention. These are the references